Good evening, everyone. So my presentation this evening, it's about aortic dissection. So these are my objectives. I'll have the introduction, clinical history, clinical findings, sonographic features, laboratory findings, other imaging modalities, clinical correlations, and conclusion. So to start with, this is my introduction. The aorta, this is the largest artery in the body, which originates at the left ventricle of the heart. The subdivision of the aorta within the chest is referred to as the thoracic aorta. Once the aorta passes through the aortic hiatus of the diaphragm, it is referred to as the abdominal aorta. It is a retroperitoneal in location and position anterior to the spine, just left to the midline. So the abdominal aorta has got three walls, layers of the walls, which is the intima, the tunica media, and the tunica adventitia. So the tunica intima, this is the innermost section of the wall, which consists of an endothelial lining and elastic tissue. Then the tunica media, this is the second layer, which consists of the smooth muscles and the elastic fibers. Then the tunica adventitia, this is the outermost layer, which consists of the collagen fibers and the elastic fibers. So the aorta, it has got also the branches. The first branch of the aorta, we've got the celiac trunk. Then the second one, we've got the superior mesenteric artery. Then we've got the renal artery. We've got the gonadal arteries. We also have the inferior
Mr. Walubita, sorry for Mr. Walubita, sorry interruption. Are your slides moving or you are explaining?
I'm explaining, I'm still on the introduction, sir.
All right, thank you. Thank you so much.
Yes, so saying there is the inferior mesenteric artery. Then we also have the common iliac arteries. So what is we're talking about aortic dissection? So aortic dissection, it's just a separation of layers of arterioles walls predominantly disturbing the intima. So this aortic dissection can be classified into two. There is what we call Stanford classification, DeBakey classification. Then under Stanford classification, there are two types. There is type A and type B. Type A, it involves the ascending aorta. Then type B, it involves the descending aorta. Then under DeBakey classification, there is type 1, which involves the entire aorta. Then there is type 2, which just involves the ascending aorta. Then there is even type 3. It only involves the descending aorta. So what causes this aortic dissection? So there are many causes of aortic dissection. One of the causes is hypertension. Then we've got trauma. We've got connective tissue disorders. We've got coarctation of the aorta. Then we also have bicuspid aortic valves. So these are just the classification I was talking about. This is type 1 under DeBakey, which involve the entire, you can see the ascending aorta, the aortic arc, the descending. So it involves the entire aorta. Then this is type 2, which just involves the ascending. Then type 3, it just involved the descending aorta. So this case presentation, the clinical history, and a 26-year male patient came to the hospital with a complaint of having difficulties in breathing, chest pain, abdominal pain, and back pain. So this patient actually, he was sent to do echo So upon doing the echo, we discovered that the ascending aorta was dilated. Then from there, that's how we required to do the abdominal ultrasound for further management. So the patient had a history of alcohol abuse. Then the patient had an episode of vomiting, then even easily fatigued. So under clinical findings, there's abdominal pain, lower back pain, intense chest pain, vomiting, and shortness of breath. Laboratory finding, the troponin were elevated, CKMB were elevated, hematuria, and D-dimers elevation. So these were the echo findings. So on echo finding, there was dilated cardiomyopathy, dilated ascending aorta. As you can see, it was measuring 5.8. As you know, the abdominal aorta, the normal measurement for the proximal, it's supposed to be not more than 2.5. Some literature will tell you 2.7. Then on the middle part, it's not supposed to be more than 2.0. Then on the distal part, I would say 1.8. So there was moderate tricuspid regurgitation. There was also mild pulmonary hypertension. So abdominal ultrasound findings, there was dilated abdominal aorta with an intima flap. Then there was mural thrombus. So these are the images which we got at Mainasoko Military Hospital, where we saw this patient. As you can see, this is abdominal aorta. Then this echogenic thing, the one you are seeing inside, this is what we call an intima flap. This is why we call it a dissection. It's a tear between the intima and the mid. So this echogenic thing, this is the intima flap. These are the other images for the abdominal aorta. This was taken in sagittal, the other one in transverse. As you can see, this is the first branch of the abdominal aorta, the celiac trunk. Then this is the superior mesenteric artery. Other imaging modalities, you can do CT scan, echo, MRI, X-ray. Though CT scan, this is the investigation of choice for aortic dissection, or I would say the gold standard, because when a patient goes for CT angiography, let me say the role of CT in this evaluation of aortic dissection, it will confirm the diagnostic, 1. 2, it will even classify the classification of the type of dissection, whether it's type A or type B. Then the other thing, it will also identify the branches or the arterial branches which are involved in that case. Then it can be even differentiate the true and the false lumen. It can also detect extravasation, or I would say hematoma, or even pericardial effusion. So under X-ray, with X-ray, you can't really confirm that there is aortic dissection, but you can just suspect. You can, when you do the chest X-ray, you can even measure the mediastinum. So if you find that when you measure the mediastinum, it's maybe greater than 8 centimeters, then you start suspecting that. So then you can send the patient for other imaging modalities. So these were the CT findings, CT angiograph findings. So CT angiograph revealed an aortic dissection from the root of the aorta to the left common iliac artery. Marked dilated ascending aorta, ascending segmental, it was measuring 8.6, and the descending segment transverse diameter, it was measuring 7.6 centimeters. Then the intima flap involving the root of the aorta through with a large neural thrombus. So these were the images we got for the same patient. As you can see, this is the false lumen, this is the true lumen, this is the intima flap here. So the true lumen, as you can see, is very small. Then the false lumen is big. The reason is very simple, because the false lumen will compress the true lumen. So these are just the images. Then this is the other image, which shows the ascending thoracic aorta here, as you can see this. Then this is the false lumen. The true lumen was measuring 82.5 millimeters. Then this is the descending aorta, thoracic aorta, which was measuring 73.2 millimeters. So in this case, like for this patient, the entire abdominal, I mean the entire aorta there was dissection, starting from the ascending going to the iliac. So this is another CT image, which shows the left common iliac artery, showing the true and the false lumen, as you can see here. So there's also a dissection here, intima flap, the true lumen, and the false lumen. Then this is the right common iliac artery. So these are our images we got for CT. Then post-surgery findings. So this patient, as we are talking, he went to South Africa for the surgery, and the surgery was conducted. It was successful. Then the findings, they found that the dilated thoracic and abdominal aorta, there was multiple mural thrombus. The stent repair was done, and the patient was discharged. As we are talking about now, the patient has been discharged. So in conclusion, aortic dissection, this is just a medical emergency with a very high mortality if is undergonized. Then aortic dissection involving the ascending aorta are treated with emergency surgery, and those involving descending aorta type 3 are usually treated with medication. With this case, it was causing CT, it was confirmed that it was aortic dissection type A, Stanford. So Stanford type A, the patient had just have to go under surgery. So imaging plays an important role in the narrowing of the diagnosis. So before I even show you my references, I would like to acknowledge the following people who helped me during this case report when we're doing this at Mainasoko. I would like to say thank you to Mr. Mlenga, Madam Toera Piri, Dr. Zuru, and even my fellow student who helped me to gather more information. And I will even want to say thank you to the patient for cooperation, because though the patient at first he didn't know that this was a serious case, but we had to push for the patient to come to the hospital. We used to call him, no, come. He thought maybe it was an easy thing, but at last I said, no, you need to be seen. So these are my references, and this is where my presentation is ending. Thank you very much.
Thank you so much, Mr. Walubita. Thank you for that very precise presentation and quick to the point.